So good morning, everyone, and welcome to our this sixth online teaching class for CNS malignancy. And this is the last lecture, and this is a very interesting lecture also, which will be taken by Dr. Tejpal. So for the moderation, I will request Dr. Raishi Agrawal to kindly proceed. She is the principal consultant at Max Vaishali, Ghaziabad. Dr. Raishi, over to you.
Thank you so much, Dr. Surbi. So, this is our teaching program on behalf of Association of Radiation Oncologists of India, UP chapter. So, I welcome you all, and today's class will be taken by Dr. Tejpal Gupta. And he doesn't need any introduction. He is a renowned name in the field of neuro radiation oncology. He is professor of radiation oncology in TMH Mumbai. So I request him to please guide us. Thank you so much, Dr. Tejpal, for accepting our invitation. Thank you so much.
Thank you, Dr. Rashi, and thank you, Dr. Surabhi. I think the UP chapter of AROI is doing a wonderful job by organizing these webinars in different aspects of management of various malignancies. And today we're going to discuss the contemporary management of medulloblastoma, which has been a difficult topic. Certainly, the radiotherapeutic management of medulloblastoma has been quite challenging ever since craniospinal irradiation became one of the mainstays of treatment, and we'll discuss some of the technical nuances of craniospinal irradiation. But in general, this lecture would pertain to all aspects of management of medulloblastoma. So, as I begin, I would just like to remind all the students and the trainees in the audience. A few years ago, the Indian Society of Neuro-Oncology actually took up this initiative of coming up with consensus guidelines for the contemporary management of medulloblastoma, particularly for the Indian setting. And this was necessitated because there was a lot of variability in the way that medulloblastoma was being managed in the country. It is one of the commonest malignant primary tumor in children, and in the last decade or so, there has been revolutionary path-breaking discoveries in understanding the biology of medulloblastoma, which has led to its classification into different subgroups. And generally, it was felt that the success rates that we see in the Western world is not typically mirrored in the Indian context. And that's why this initiative was taken. And this is published in Neurology India, and it's free for download from the Neurology India website. And also, a link is provided on the Indian Society of Neuro-Oncology website. So we would discuss all aspects, as I said. So what are the imaging guidelines? What are the neurosurgical principles? The neuropathology reporting of medulloblastoma? What is the contemporary consensus classification? The contemporary risk stratification? Guidelines for adjuvant radiotherapy, including some details on contouring and prescription and planning of craniospinal irradiation, and lastly, some ongoing clinical trials based on upfront molecular subgrouping. So again, this is available on the ISNO guidelines in the publication. So for when you suspect a medulloblastoma, when a child presents with features of raised ICT, headache, vomiting, and imbalance, and there is a lesion in the posterior fossa in the midline. These are the recommended MRI sequences that one needs to do, and this is basically divided into a mandatory requirement and a preferable though optional requirement. And this was sort of done to ensure that even, any center with an MRI capability can do at least the minimal desirable mandatory acquisitions, and those with higher expertise could do further sequences as well. But one thing is for sure, that contrast enhanced MRI of the brain, including diffusion weighted images, because diffusion, most medulloblastomas would show severely restricted diffusion is required. Whenever we suspect a medulloblastoma, a sagittal screening of the spine should always be done. A sagittal post-contrast screening of the spine is also mandated. Because the incidence of leptomeningeal disease is rather high in medulloblastomas. So this is as far as the imaging MR is concerned. Many a times we do see and we come across cases where there is no preoperative MRI, as the child has been operated on the basis of a CT scan. That is done only when the child is too sick to undergo any MRI, which takes a longer time and the child may not cooperate and the child is too sick. Sometimes many people would do a CSF diversion to make the child better and then proceed with an MRI, but occasionally we do see surgeries being performed based on the CT scan that demonstrates a mass lesion in the posterior fossa in the midline, suspicious for a medulloblastoma. Now, once you diagnose or you suspect a medulloblastoma, the neurosurgical treatment becomes the first line treatment. Of course, patients have to be managed symptomatically at initial presentation, but routine use of VP shunt prior to surgery is actually not recommended and is unnecessary. But in case a shunt is required, you should avoid rapid decompression and over drainage of the CSF. Mostly dexamethasone should be given for medical decompression, but other cerebral decongestants such as furosemide and mannitol can also help. The best way to reduce the symptoms and decompress the brain is actually definitive surgery. So the definitive surgery should be done as quickly as possible. Now, surgeons have their preferred sort of position for the surgeries. Prone position is generally the most preferred position by most neurosurgeons, but it can be done in the sitting position as well. For midline tumors, midline suboccipital craniectomy is the preferred approach, but for slight lateralized or tumors getting into the foramen, a paramedian or retrosigmoid approach may also be used. One thing that we need to remember, that for all neurosurgery, including medulloblastoma surgery, maximal safe resection remains the guiding principle. So you should not be very overly aggressive in trying to resect every bit of the tumor and precipitate deficits. Rather, you should use a maximal safe resection as your guiding principle. Now, the outcomes by extent of resection. I mean, there traditionally aggressive surgical resection was recommended because residual tumor more than 1.5 was considered to be not good for overall outcomes. In the last few years, that has been challenged, particularly after the advent of the molecular subgrouping, and we'll see some of the data pertaining to that. So this is a retrospective analysis of over 700 patients of molecularly characterized medulloblastoma, where the extent of resection was sort of looked at, stratified by the molecular subgrouping. So in Wnt pathway, the sonic hedgehog pathway, the group 3 and the group 4 medulloblastomas. And essentially what it showed was that if you achieve a NTR or GTR, actually there is no difference in outcome compared to STR in Wnt, SHH and group 3. But there is some difference in PFS in group 4. So group 4 tumors tend to have a significantly worse PFS if you achieve a STR as opposed to gross total resection or near total resection. So what the authors concluded was that the prognostic benefit of the increased extent of resection gets attenuated after you take into account the molecular subgrouping. But they still maintain that maximal safe resection should remain the standard of care, but surgical removal of small residual portions aggressively is not recommended when the likelihood of neurological morbidity is high. So this is what the authors concluded, that the value of increased craniospinal irradiation for patients with more than 1.5 centimeters square should also be questioned and explored in future prospective trials, because traditionally anything more than 1.5 centimeters square was a high risk feature. Now, coming to after the surgery, you get the specimen, the pathologist looks at it and describes the histomorphology based on the hematoxylin and eosin staining. So again, in the ISNO consensus guidelines, there is this recommended testing for medulloblastoma, again divided into a minimum desirable or mandatory testing, and preferable though optional tests if further facilities are available. The Indian Society was pretty cognizant of the fact that several centers, particularly neurosurgical centers situated in medical colleges, may not have access to routine immunohistochemistry. Although it is strongly encouraged that those tissue samples be sent to higher centers or to centers where IHC facilities and molecular testing facilities exist. But at bare minimum, you should do the hematoxylin eosin staining, the reticulin staining, and the MIB1 labeling index. If you have facilities for IHC, you could do synaptophysin, NSE, and neuronal markers, and also use other IHCs to differentiate medulloblastoma from high-grade gliomas such as small cell GBM, anaplastic ependymoma, other embryonal tumors that arise in the posterior fossa, such as the ATRT, which shows INI1 loss, and the embryonal tumor with multi-layered rosettes, which is positive for Lin28 on immunohistochemistry. So important to differentiate other embryonal tumors from medulloblastoma based on immunohistochemical staining. The 2016 update of WHO classification, the 4th edition, and now recently the publication of the 5th edition of classification of CNS tumors essentially recommends multi-layered reporting for all brain tumors, including medulloblastoma. Layer 1 is the integrated diagnosis. Layer 2 is the histological classification. Layer 3 is the WHO grade, which reflects the natural history, and layer 4 is the molecular information. And this is how the integrated diagnosis for medulloblastoma is with the correlates in terms of histological subtyping and outcomes. So the WHO defines it as medulloblastoma Wnt activated, medulloblastoma SHH activated, TP53 mutant, and TP53 wild type, and medulloblastoma non-Wnt, non-SHH, which could be either group 3 or a group 4. Ideally, or to have a more refined or nuanced prognostication, you should separate the non-Wnt, non-SHH group 3 from non-Wnt, non-SHH group 4. But there are limitations to testing based on IHC, which cannot differentiate between group 3 and group 4, and can only tell you whether it is non-Wnt, non-SHH. Could be either group 3 or group 4. So this is from the WHO 2016 update. The integrated diagnosis would be medulloblastoma. You provide the histological subtype, the molecular subgroup, and it is always a grade 4 tumor. So histological grade is always grade 4. Within the histological subtypes, you could have the classic, the desmoplastic nodular, medulloblastoma with extensive nodularity, or the large cell anaplastic. And molecular subgrouping, Wnt activated, SHH activated, either TP53 or TP53 wild type, mutant or wild type, and non-Wnt, non-SHH. If you can divide group 3 and group 4, that would be really good. And certain other genetic alterations which define or which assign prognosis, if available, should also be considered. Now, as I said, in the last 10-15 years, we've understood that medulloblastoma is not a single disease entity, and it's a heterogeneous group of tumors which comprises several different molecular subgroups, each of which has its distinct demographics, clinical radiological features, developmental origins, molecular genetics, biological behavior, and even outcomes. So it's not a single disease as we had thought for last over 80 years since it was first described in 1925 by as a distinct tumor entity. So Michael Taylor and his group actually published this consensus classification nearly a decade ago in 2012, wherein they sort of had a consensus amongst the several groups that had published data on molecular subclassification of medulloblastoma, and this was agreed that it comprises of four broad subgroups: the WINT, the SHH, the Group 3, and the Group 4, each of which has its own distinct demographics, clinical features, genetics, gene expression, and as well as outcome. As I said, the cell of origin is somewhat different. The tumorigenic event is different amongst the subgroups. The underlying biological mechanisms are proposed to be different, and there are candidate driver genes within each of these subgroups. Now, how do you assess the molecular subgroup once the tissue is out? And there are several platforms for doing molecular subgrouping, and depending on the availability and the affordability, you could choose one. The easiest is, of course, the immunohistochemistry using three antibody array, which is nuclear beta-catenin, cytoplasmic GAB1, and nuclear YAP1. So based on these three, the beta-catenin, the GAB1, and the YAP1, you can actually say whether it is a WINT SHH or a non-WINT non-SHH. Of course, you can do higher level analysis using gene expression profiling, microRNA profiling, the nanostring assay, and also combine them with some other genetic alterations such as monosomy 6, CTNNB1 mutation for WINT pathway medulloblastoma, and GLE2 amplification for SHH, and MYC amplification for non-WINT non-SHH. So this was the seminal paper published by Northcott and colleagues in JCO, where they first reported the four subgroups of medulloblastoma. And this is our own data from Tara Hospital, published again nearly a decade ago, where we looked at real-time RT-PCR assay based on the differential expression of microRNAs and protein coding genes for molecular classification of medulloblastomas. And in accordance with the consensus classification, we had WINT, SHH Group 3 and Group 4 in a cohort of 101 medulloblastoma samples. As I said, IHC is the easiest way. So this was published by Ellison's group, where they looked at GAB1, beta-catenin, filamin A, and YAP1. And GAB1 cytoplasmic positivity would be seen in SHH, nuclear beta-catenin positivity in the WINT, and the YAP1 nuclear and cytoplasmic positivity negativity was seen in the non-WINT non-SHH. So based on that, you could classify these tumors into these three molecular subgroups. This was further validated by two independent Indian cohorts, one at AIIMS and one at NIMHANS, and both of these has been published in the peer-reviewed literature. Now, why do we need to come to the molecular biology? Because of its impact on outcomes. If you see across all age groups, infant, children, and medulloblastoma, molecular subgrouping retains its significance even on multivariate analysis. And that's why it is important to have the molecular profiling done on medulloblastoma to understand how it is going to behave. This prognostic significance again has been validated by our group. This is data from our own institution at Tata Hospital, where we showed the prognostic significance of the molecular subgrouping. Subsequently, the AIIMS cohort published their data, where again the outcomes were statistically significant based on molecular subgrouping. And more recently, the NIMHANS group has also published their data of molecular subgrouping in medulloblastoma. So there is corroboration of this prognostic significance across three major Indian institutions regarding the molecular subgrouping of medulloblastoma. Now, we briefly discussed that the traditional risk stratification in medulloblastoma has always been clinico-radiological. So this is again a seminal paper from COG published in JCO in 1999, where they showed that younger age, less than 3 years, presence of residual tumor more than 1.5 centimeters square, and presence of metastasis all led to inferior outcomes in children with medulloblastoma. And presence of any of any one of these risk features was considered as high risk. So average risk was defined as age more than 3 years, residual tumor less than 1.5 centimeters square, and no metastasis, whereas presence of any one of these features less than 3 years, residual tumor more than 1.5 centimeters square, and leptomeningeal metastasis was considered as a high risk feature. But this traditional risk stratification lacked any information on the molecular biology of medulloblastoma, which has tremendous potential for refinement of the risk stratification. So how do you refine risk stratification for assigning therapy? So as I said, traditionally age, residual tumor, and M stage were used. But if you incorporate histology and molecular biology into this, you can actually refine the risk stratification. And we'll just come in a moment to that. So this is stratification by histology. This is data from both from the German group as well as from the North American group. And if you see desmoplastic versus classic versus anaplastic, children with desmoplastic medulloblastoma do exceedingly well as opposed to children with anaplastic medulloblastoma. So therein lies some of the answer that if you use histological subtype, you can actually prognosticate better. These are the survival curves for these patients. Also, if you look at nuclear beta-catenin, which is a marker of the Wnt pathway medulloblastoma, patients with accumulation of nuclear beta-catenin had a 92% 10-year survival, as opposed to patients without nuclear beta-catenin who had only 65% 10-year survival. So again, histology and biology are important prognostic factors. So this has now led to a consensus in terms of risk stratification of medulloblastoma in the molecular era. And now it is no longer classified as average risk and high risk. And now you have a more nuanced classification into 4 risk groups, which is low risk, standard risk, high risk, and very high risk. And that's based on the expected long-term survival. So the low risk medulloblastoma, you would expect more than 90% 5-year survival. In standard risk, it is expected to have more than between 75 to 90% 5-year survival. The high risk, 50 to 75% survival, and very high risk, less than 50% survival. Note that P53 mutant SHH and metastatic group 3 medulloblastoma fall in the very high risk. Localized Wnt and localized group 4 with chromosome 11 loss or whole chromosome 17 gain are low risk with more than 90% 5-year survival. So it's important to now prognosticate into 4 sort of classes rather than into just the 2 classes. Switching to the technical aspects of radiation therapy in medulloblastoma. So as we all know, medulloblastoma is traditionally treated with craniospinal irradiation to the neuraxis plus the boost irradiation. We will come to the prescription towards the end of this part of the talk. So craniospinal radiation has been an integral part of the multimodality management of medulloblastoma since it was first used in medulloblastoma in the 1950s. Prior to that, the outcomes of medulloblastoma were dismal with surgery and focal irradiation, 0% 5-year survival. With the advent of CSI, the 5-year survivals improved beyond 50%, and now with contemporary multimodality management, including chemotherapy in the low risk, as I said, 90% 5-year survival, and even in the high risk and the very high risk, you have between 30 to 60% 5-year survivals. So technically, it is a complex and challenging process because of the very large and irregular volume of irradiation, multiple field junctions which necessitate an abutment dosimetry, and there are several adjacent critical structures that need sparing. There is a long history of quality assurance in delivery, and outcomes have been correlated with deviations in radiotherapy delivery for medulloblastoma. And of course, although it is curative for it is curative for a large majority of patients, it is associated with significant acute and late toxicity. So we'll be briefly discussing the positioning, immobilization, delineation of target volumes, conventional planning, high precision techniques, and verification and quality assurance. So traditionally, So when I trained in radiation oncology, we didn't have any image guidance. We didn't have 3D systems, and what we generally were used to treating was using the prone position with a prone headrest and chin support. Over the years, that has changed. Now we use vacuum bags and dual immobilization and all sorts of fancy stuff on an all-in-one base plate. But traditionally, medulloblastoma was treated in the prone position because you could verify the field on the surface of the patient. So I'll just briefly, for the sake of the students, I know that for the most part, nobody now does CSI in the prone position, and everybody uses preferably the supine position. But just for the importance, for the sake of completion, I'm talking about prone CSI using the conventional simulation. So generally, you would simulate the spinal field first using the SSD setup, and generally the borders of the spinal field would be superior would be at C2, C3 junction to avoid exiting through the oral cavity. The inferior would be at the S1, S2 junction, or if you have a sagittal MRI, you could look at the identify the lower end of the thecal sac and place your field border 1 centimeter below that. Laterally, normally you would cover the entire vertebral body with a 1 to 1.5 centimeter margin on either side. Must ensure that the sacral foramina are covered. So generally, typically a field width of 6 to 7 centimeter for a younger child, and sometimes a spade field for the older child. And this is the simulator film for a direct posterior spinal field in a child with medulloblastoma. As I said, in young children, the entire spinal field can be encompassed in a single field. However, in older children, you would need to use two adjacent spinal fields, the upper spinal field and the lower spinal field. One way to avoid two adjacent spinal field would be to use a extended SSD, but that would increase the exit dose. If you use two adjacent spinal field, you have to use gap at the skin surface, and generally, the two adjacent field borders would have the match line beyond the spinal canal. And this spinal field has to be geometrically matched to the cranial field using couch and collimator rotation. So typically, this is how the cranial field simulation would happen. The brain and the upper cervical spine are treated with shaped opposite lateral cranial fields. The cranial field border anterior would be anterior, superior, and posterior would actually be in air. Inferior would be at C2, C3 or C3, C4 junction, depending on where you have taken your spinal field. And either use a conformal block to shield the eyes, oral cavity, and the neck, or in the last decade or so, mostly using MLCs. Now, cranial fields are geometrically matched onto the direct posterior spinal field using the couch rotation and the collimator rotation. And typically, a couch rotation, there is a complicated formula for that. I don't think it really, you need to remember that formula, but generally, when we were doing conventional simulation, we would give a couch rotation of 6 degree and a collimator rotation between 10 to 12 degree to match with the posterior spinal field. A gap of 3 to 5 millimeter is recommended between the brain and spinal fields, and you need to feather that gap or the field junction periodically throughout the treatment. So in summary, prone craniospinal, you use a whole body immobilization, a vac lock, or with a supine with a prone headrest. Two lateral cranial fields geometrically matched onto a direct posterior spinal field. Use the couch and collimator rotation in the cranial field to match the beam divergence, and you can verify the junction on the patient's surface at the time of treatment delivery. As one would appreciate, there are pros and cons of the positioning. Prone has been used since decades. Most of the outcome data is from prone CSI. You can verify it on the surface, but it is generally uncomfortable for the patient. And for younger children, you can't really administer anesthesia in the prone position, and it is prone to larger setup errors. On the other hand, supine has enhanced patient comfort, suited for anesthesia, more reproducible, but you cannot verify directly on the surface, and there is a learning curve associated with the supine CSI, and the outcome data from supine CSI is not as mature as the prone CSI. As I said, in contemporary radiation oncology practice, supine has become the preferred position, and we will just briefly discuss CSI using the conventional beam geometry, which is the fixed field geometry, which is generally the recommended geometry, and also advanced proton-based CSI techniques using rotational IMRT. So supine CSI, when we do using a fixed field geometry using the SAD technique, so this is a schematic representation. It is very similar to the prone field, but what we do is use a asymmetric half beam block for the bilateral cranial fields which are shaped with MLCs. The geometric, the divergence of the spinal field is matched geometrically using a collimator rotation. You don't need a couch rotation here because we are using a half beam block, and you require only a longitudinal couch shift. So traditionally we keep the longitudinal couch shift fixed at 20 centimeter to treat the spinal field. And in adults, if you have a lower spinal field, you can move that longitudinally by another 20 centimeters, so at 40 centimeter. And this is how, this is a simple fixed field geometry technique that can be used for supine CSI. If you want to make the lower spine field parallel to the divergence of the upper spinal field, that is also doable if you just rotate the couch and then slightly angulate the gantry. So this is how that would happen. And this is also if you want to make the divergence, match the divergence of the upper spinal field with the lower spinal field. As I said, you need to feather the junction periodically, and traditionally we use three junctions. I mean, three times we feather the junction during a course of craniospinal irradiation. That is just to ensure that there are no consistent cold or hot spots at the junction. Now, since the last 7 to 10 years, most people have moved towards doing delineation of target volumes and organs at risk for craniospinal. So you would need to acquire axial planning CT data set, 5 millimeter slice thickness from vertex till upper thighs. The entire neuraxis is your target volume. So we generate CTV brain and CTV spine, and then give a isotropic margin all around to generate the respective PTVs. The CTV spine should extend till the lower end of the thecal sac, and virtually you have to draw every organ in the body that you want to spare, and that includes every organ that you can think of. So all organs need to be contoured to be spared. A few years ago, the PSYOP European Brain Tumor Group came out with this consensus guideline on craniospinal target volume delineation for high precision radiotherapy. And again, this is in the Green Journal, and the students and trainees should refer to this manual when they are starting doing contouring for craniospinal irradiation. I will just briefly. So they have recommended that we draw a CTV cranial and a CTV spinal. I mean, in TMH we call CTV brain and CTV spine, really doesn't matter, whatever you call it. What they recommend is that for delineation of the CTV cranial target volume, you should use the bony window setting, ensure that the cribriform plate and the innermost part of the temporal lobe, the entire pituitary fossa which contains CSF are included in that CTV, and all the extensions of the CSF within the dural sheath of the cranial nerves are also included. So the superior orbital fissure, the foramen rotundum, the internal auditory meatus, the foramen ovale, the jugular foramen, and the hypoglossal canal. So all of your target volume CTV should extend into that. For CTV spinal, the entire subarachnoid space with extension along the nerve roots laterally should also be included. So this is what we have been doing traditionally, even with the conventional techniques. But now when you start contouring, you have to make sure that you draw that or include that in your target volume to ensure that the high doses go to that area. There are no typical OAR constraints defined for CSI, but over the years, several groups have been using them. This is a typical example of, we use 35 grain 21 fraction as our standard dose CSI, and this is our own institutional sort of OAR constraints. If you are using a reduced dose CSI such as 23.4, then you have to reduce or sort of tighten these constraints accordingly. Now, as I said, people have moved towards doing IMRT in the supine position, and we also tried a dosimetric study of that nearly 10 years ago. So the brain is planned using half beam block MLC shaped collimated bilateral fields, but the spinal target is planned using 5 field IMRT, posterior beam arrangement. one direct posterior and two posterior obliques on either side, and that generally gives you quite a nice distribution. With the advent of VMAT, this has changed. Now most people don't do a standard sort of static field IMRT, and rotational IMRT is done, typically planned using 2 isocenters, or most of the times actually these days 3 isocenters. The first isocenter is in the brain and upper spine. The second isocenter, depending on the length of the volume, would be in the thoracic, and the third isocenter in the lumbar spine. 2 to 3 arcs per isocenter with variable arc length, and you can use partial arcs with avoidance sectors, which reduces the dose anteriorly into the spinal segment, and this ensures rapid planning and faster delivery. We had been using tomotherapy-based rotational IMRT. More recently, in the last 1 year, we are now using the rapid arc-based CSI also. So tomotherapy-based rotational IMRT makes life more simple as far as CSI is concerned, because the couch translates to the ring as the gantry rotates around the patient, and the entire target volume, the brain and spine, is encompassed in a single plan, and you don't have any field junctions. We typically use directional block for the eyes and kidneys to prevent entry doses, and we can use a complete block for the lens even to prevent the exit doses. We also use constraints for the pelvis to reduce the spillage and hematologic toxicity. So this is how a typical high dose wash for CSI on tomotherapy looks like, and this is the DVH for that. The planning part is okay, but it's difficult to execute this treatment in the supine position, as you can't verify directly on the surface, and therein comes the use of volumetric image guidance. And we were fortunate to have tomotherapy since 2007 at our institution. And in the first 3-4 years that we treated patients on tomotherapy, we analyzed that data in terms of what would be the sort of setup error at the brain level, at the upper dorsal spinal level, and at the lumbar level, using 3 MVCT scans for all patients that we treated with craniospinal. And what we did see was that there was a substantial site-dependent variability in displacements that increased systematically from brain towards the lower spine, which means that you have to have a higher setup margin for the lower spine than the brain and the upper spine. What about clinical outcomes with IMRT for CSI? Again, not very robust data, because the outcomes have been reported, early outcomes have been reported, and only in patients, less than 20 patients in most of the groups. I think in the last couple of years, some more data has been reported, but now most people are moving, wherever protons are available, moving towards intensity modulated proton therapy. But in general, their outcome data with IMRT for CSI has been sparse, although it has been increasing steadily over the years. What would be the most optimal technique to do photon-based CSI? I think it depends on availability and resources, but since we've been using tomotherapy for almost last 15 years, we feel that rotational IMRT, particularly tomotherapy, seems to be the best suited for craniospinal irradiation. Of course, there is the case for proton beam therapy, and this is the classic sort of dose depth dose characteristics, comparing the photon beam with the spread out Bragg peak of a proton beam, and very clearly you can see there is a clear dosimetric benefit of protons over photons. Now, coming to the boost irradiation in medulloblastoma, traditionally treated, the entire posterior fossa was treated with bilateral parallel opposed field or an oblique wedge pair technique, that subsequently became more conformal with 3D conformal techniques. But the contemporary practice is to treat just the tumor bed with some margins, either using a multi-field conformal technique or increasingly with IMRT or IMBT. So this is again a fluoroscopy-based, simulator-based posterior fossa boost simulation. On a simulator film, you could draw a line from the posterior clinoid marked as A to the internal occipital protuberance, and draw a line bisecting and perpendicular to AB, which is depicted as DE. The tentorial apex is half the distance from E to D, and you can then draw your portal with 1 to 2 centimeter margin around this, and that would cover your posterior fossa quite well. As I said, increasingly more conformal techniques, including an oblique wedge pair, and then 6-field non-coplanar stereotactic conformal technique, and now the IMRT technique. So this compares the tumor bed boost irradiation using 2D parallel opposed field 3D conformal technique and the IMRT multi-field IMRT technique. And you can see that the conformity is much better with the IMRT technique. This is the dose wash and the DVH of tumor bed boost irradiation on helical tomotherapy. Of course, protons can spare normal supratentorial brain much better and the cochlea much better. So there is significant reduction in non-target tissue irradiation. The target volumes for boost irradiation have also evolved over the years. Now from posterior fossa, we have come down to the gross disease or the tumor bed with small margin of 5 millimeter. Now, as I said, there has been a long history of quality assurance in radiotherapy planning and delivery for CSI, and this is because there has been publications that have reported direct adverse impact of protocol deviations on survival in medulloblastoma. So these are publications from 1990s till 2000, where any low quality radiotherapy was associated with worse outcomes as opposed to high quality radiotherapy based on peer review of radiotherapy planning and delivery. Coming to the prescription, typically for so-called standard risk disease, 23.4 gray with adjuvant chemo is recommended. Many a times in adult medullos, even for standard risk, we do the full dose CSI without chemotherapy. We use 35 in 21, but generally the North American standard is 36 gray in 20 fractions. For tumor bed boost, if you have used the reduced dose CSI, and then you use 30.6 gray. If you have used standard dose CSI, then you use 18 to 19.8 gray. High risk disease, of course, you have to use full dose CSI 35 to 36 gray, and sometimes even extended dose CSI, which is 39.6 to 40 gray. And for a high risk disease, if it is multifocal disease in the posterior fossa, then you might need to do the whole posterior fossa irradiation and also boost some of the nodular metastatic deposits. So in brief, the total tumor bed dose is generally 54 to 55 gray in 30 to 32 fractions over a period of 6 to 6.5 weeks in medulloblastoma. What about adjuvant chemo? There are several chemotherapy regimens that can be used. Packard's regimen. There is also a regimen of cisplatin cyclophosphamide vincristine. For the infant medullo less than 3 years, you can use carboplatin cyclophosphamide etoposide. There is no significant difference in any of these regimens. They are pretty much similar in terms of toxicity and outcomes. And depending on your pediatric oncologist's comfort and convenience, any one of these regimens can be used. Now, there is a cost of cure in medulloblastoma, both in terms of clinical as well as social. And overall, there is reduced health-related quality of life in long-term survivors. So how do we optimize the radiation therapy? One is to use risk-adapted prescription of adjuvant radiotherapy. You reduce the dose for average risk disease or favorable biology disease. You reduce the volume of irradiation, just boost the tumor bed and not the posterior fossa. And you can intensify therapy in high-risk medulloblastoma. Very important, you start the radiotherapy within 4 weeks of the surgery and complete the radiation within 7 weeks, an overall treatment time of 50 days. Maintain good quality of radiation therapy by minimizing deviation and complying to the protocol specifications. Leverage radiobiology and modify fractionation if feasible, using either hyperfractionated or accelerated approaches, and integrate and adopt a new or novel technologies such as IMRT, IGRT, and if available, proton beam therapy. So this is one of the recent publications from the Children's Oncology Group, ACNS 0331, where they reduced the dose and the volume of radiotherapy in children with newly diagnosed average risk medulloblastoma. These were not molecularly defined average risk. They were based on the traditional classification, as this trial was conceived way back in 2003. So this is the Consort diagram. So what they did was essentially all children were randomized to whole posterior fossa versus involved villi irradiation, and younger children between the age of 3 to 7 years underwent another randomization, which was 18 gray CSI versus 23.4 gray CSI. So the low dose CSI versus the standard dose CSI. And these are the Kaplan-Meier curves. So what you can see that there was no difference in either EFS or OS based on whether the whole posterior fossa was irradiated or only the tumor bed was irradiated. But in children less than 7 years of age, when they reduced the dose to 18 gray, there was significantly inferior event-free survival and overall survival. So the conclusion was that physicians can choose a smaller volume but not reduce the dose in molecularly unselected average risk medulloblastoma. We also tried to reduce radiotherapy doses in children with Wnt pathway medulloblastoma, and this manuscript has just been accepted in JAMA Oncology. So children with Wnt pathway medulloblastoma with no significant residual tumor, we avoided upfront craniospinal irradiation, treated them with focal radiotherapy followed by chemotherapy. What did we get? That study was terminated prematurely after 7 children were accrued. The target accrual was 60 patients, but we had to stop it prematurely after 7 patients. So all patients completed the 54 gray and 30 fraction to the tumor bed and received adjuvant systemic chemotherapy. But 3 children relapsed in the near axis at between 15 to 24 months after focal IMRT. And although they were salvaged with CSI with conformal avoidance of the previously irradiated bed, plus boost to the metastatic deposits and further chemotherapy, we had to terminate the study because of unacceptably high risk of neuraxial failure. The other 3 children are alive with no evidence of disease more than 2 years after index diagnosis. And this is just one representative case vignette from the study cohort. You can see neuraxial failure in the brain as well as the spine. We treated that with salvage CSI with boost to the metastatic deposits and conformal avoidance of the previous irradiated bed. And the D and E images show complete response after the radiation. This child continues to do well after 2 years after the salvage treatment as well. But because 3 out of the 7 children relapsed, we stopped the study. As I said, you can add carboplatin to intensify treatment, and this is again a randomized trial from the Children's Oncology Group, again ACNF 0332, conceived in 2003. This randomized patients to carboplatin or without carboplatin. These are all high risk, molecularly, not molecularly defined, but high risk by traditional criteria. So if you see the curve B, which is the lower curve, patients treated with carboplatin had somewhat superior event-free survival as opposed to patients who did not receive concurrent carboplatin. And when they stratified them by molecular subgroup, what was striking was that the benefit of concurrent carboplatin was predominantly in the group 3 medulloblastoma. So Wnt, SHH and group 4 did not actually benefit, and the benefit of concurrent carboplatin was largely driven by the group 3 medulloblastoma. We also published our experience of using concurrent carboplatin with full dose craniospinal irradiation in high risk medulloblastoma earlier last year. And this is a cohort of close to 100 patients where we got overall survival of 60%, which is nearly 10% more than the standard if you compare it to historical controls from our own institution. And we saw that M stage and large cell histology came out as significant prognostic factors. So patients with M plus disease and patients with large cell anaplastic did much worse despite the addition of concurrent carboplatin. A lot of signaling pathways have been identified in the medulloblastoma, and that has led to some development of targeted therapy. The SHH pathway has been the most actively looked after or the explored pathway, and there are several ongoing clinical trials that look at targeting the SHH pathway. Some of the SHH inhibitors are actually have been tested in phase 2 also in medulloblastoma, and currently in phase 3 testing in medulloblastoma. Coming to the last part, advancement in sciences and in medicine happened with clinical trials, and in 2016 there was a working group meeting which led to this consensus for the design of next generation clinical trials in medulloblastoma. So it was strongly recommended that henceforth all clinical trials of medulloblastoma should be molecularly informed. And there should be a real-time neuroimaging, neuropathology, and radiotherapy planning review, central review of all cases to ensure quality as far as medulloblastoma clinical trials are concerned. These are some of the currently ongoing clinical trials which are based on upfront molecular testing. The SJMB12 from the St. Jude's group, the COG-ACNS 1422. There is this, the pilot study assessing the feasibility of surgery and chemotherapy only approach was actually suspended, just like we had to suspend the Forwind study. This was the Johns Hopkins study. After accruing 6 patients, the first 2 patients on their study relapsed and they had to suspend that study as well. The PSYOP-NET5 is an ongoing European study, and there is the Head Start 4 study, which is happening in North America. So in brief, this is what the current sort of when you get a newly diagnosed medulloblastoma, you divide it into the 4 molecular subgroups, and based on certain other characteristics, you would sort of qualify them into the low risk or the standard risk, high risk, or the very high risk, and devise your treatment strategy accordingly. There is a potential for de-escalating in the low risk subgroup, and of course testing targeted treatments in the SHH pathway medulloblastoma, and intensifying treatment for the high risk and the very high risk subgroup. This is the timeline of progress in medulloblastoma, and I think that was the last slide, and I'm happy to take questions.
Thank you so much, Dr. Tejpal. It was a nice lecture, and there are so many questions in chat box. So I am reading the first question. Do you prescribe some drugs with radiation? MSET, Dexona, do you prescribe something?
Yeah, so craniospinal, not Dexona. I don't think Dexona is recommended. With craniospinal irradiation, we always give a anti-emetic, typically ondansetron. Occasionally, we've had to switch over to granisetron. And I can remember only a handful of patients, less than 5% would require dexamethasone for intractable vomiting, maybe for a few days. Most of the children don't need dexamethasone.
Okay. So another question, I think that you have covered. Should we include the sacral foramina and CSI?
What foramina?
Sacral.
The PSYOP E guidelines suggests not to include. I don't necessarily agree with that guideline. I have been covering the sacral foramina for the last 15 years, and I don't see any compelling reason to stop doing that. Yes, I agree that the PSYOP guidelines, based on 10 patients MRI scans, they sort of decided that the CSF does not circulate there, or so it's not required. But I really don't think, I am not so sure whether the entire European consortium also agrees to that. It's based on a data set, 10 MRI data set, where they have said that all other foramina they are saying you should cover, but the sacral foramina, see, traditionally you have to remember that the spade field was used with a slightly broader sacral sort of lateral width. That was to ensure that the sacral foramina are covered. So I really don't think, I think unless somebody really demonstrates whatever has been your practice, I think if you were doing, you are covering the sacral fields in your conventional simulation, there is no reason to exclude that.
Yeah, thank you so much. And next question is, you have said that we should cover optic nerve. Should we cover some part of retina also when we are doing CSI?
No. So optic nerve. So there is some debate on the coverage of the optic nerve. Again, the PSYOP group actually suggests that the optic nerve, entire optic nerve till its insertion should be covered. That is what their recommendation is. Again, that is based on an MRI showing CSF flow till the insertion into the retina, again based on 10 MRI scans. If you look at the French guidelines, if you look at the North American guidelines, the proximal optic nerve is what is supposed to be included, and that is what we traditionally do. We include the proximal half of the optic nerve in the CTV and then give it a 5 millimeter PTV. So it sort of abuts the retina, or it just about is short of the retina, but certainly retina is not supposed to be included into the CTV. Certainly not.
Yeah, thank you. Yeah, Dr. Tejpal, I request you, can you share with me that picture of contouring on my WhatsApp request?
I will send that, and I think there is an atlas also of the PSI-OP-E. There is an atlas online available. I will certainly share that and the Green Journal paper as well. And there is a link to the atlas which is available on the PSI-OP-E BTG group. It is helpful, at least when you start doing a high precision photon based CSI. I think everybody should at least go through that atlas and the paper, so that it becomes easier to do things. You may not necessarily agree with all what they have said, but it's a good beginning, I think.
Next question regarding CBC. What should be the frequency of repeating CBC, and what time when you think, yes, this is a TLC, when we should stop that treatment?
I don't agree regarding stopping treatment. So we typically do, so when we were doing standard, so the fixed field geometry with a direct posterior spinal field, once a week CBC actually is enough if you're not adding concurrent carboplatin. I mean, we use a lot of concurrent carboplatin, and that means that we have to do at least twice a week. But if you're not adding concurrent carboplatin, is just radiotherapy, then once a week with fixed field geometry is enough. With VMAT, rotational IMRT, your hematologic toxicity increases because you're irradiating a lot of the pelvis and to lower doses. The entire body gets a lot of lower doses. So there we typically do twice a week. In the first week we do once a week, but from second week onwards we do twice a week, or even sometimes more frequently if required. Our threshold for, so when we use concurrent carboplatin, we give GCSF the moment the ANC falls below 1000. In patients which are not on chemotherapy, we don't necessarily use GCSF till the counts drop to less than 500. So if the counts come to 500 or the patient develops fever, then we would use GCSF. Otherwise not. I don't, even for platelets, you can continue up to 50,000 platelet. There is absolutely no problem. Even actually above 25 to 30,000 also there is no problem, unless the patient has received pre-irradiation chemotherapy. Many a times we do pre-irradiation chemotherapy for widely metastatic medulloblastoma 2-3 cycles, and then we do the CSI. And that is the time when it becomes very difficult to sort of give the full dose CSI without supporting the patient with growth factors and platelets. But in general, actually, not required.
Yeah, we should understand that we should not stop
radiation. So I think the radiation is the most important part, and any break. One trick that we used previously was to sort of stop the CSI, start the boost, and as the counts recover, then switch back to the CSI. That can be something that can be done. I mean, you're at least treating the gross disease, whatever you want to treat. But I think ideally we would want to just complete the CSI and then switch over to the boost.
Yeah. So another question is head position in prone CSI, is straight, flex, or extended?
So in prone CSI, generally it should be slightly extended. If you flex it, then most of the exit from the spinal beam would go into the oral cavity and the dentition. So that is not recommended. So it should be slightly extended so that the exiting spinal field does not exit through the oral cavity and the dentition. It will exit through the neck.
And Dr. Amol has asked, what is your preference between IMRT and rapid arc?
We don't do static field IMRT at all. We've never, I mean, we did just the dosimetric study that we published in 2009. We never implemented that clinically. We already had the tomotherapy by that time. So it was rotational IMRT from 2007 till 22. We have been doing rotational IMRT. If we so when we treat these patients on standard LINAC for the last 10 years, we've been using a fixed field geometry, the two lateral cranial fields matched onto a direct posterior spinal field using daily cone beam KVCT image guidance. The rapid arc CSI is something that we've started only in the last 1 year. I was a bit hesitant to start the rapid arc CSI because of the availability of tomotherapy, which makes life so easy as far as CSI is concerned.
Yeah. So we have, I think, 8-9 questions more. If only biopsy is done, then should we ask neurosurgeon to go ahead with, or we should? Should we ask
I think this is a very wrong notion to do only biopsy. It should still be a maximal safe resection unless there is a medical contraindication. I mean, suppose the surgeon went in and there was massive bleeding or a bradycardia or a cardiac event, and there is no way that the surgeon can go in again. Then, of course, you have to go ahead with the radiotherapy and chemotherapy. But otherwise, there is no concept of doing a biopsy and deciding, okay, ये ependymoma है तो अब इसको हम surgery करें. That at first attempt you should remove as much as you can safely.
Next question is, what points should we include when we counsel about late toxicity?
Everything. I mean, I think the first thing that if you have information regarding the molecular subgroup and you know which risk category this child gets into, I think the first thing has to be what is the likely outcome. I mean, whether the child is going to survive. So if it's a group 3 metastatic medulloblastoma with MYC amplification, we really don't get into the late toxicity discussion at all, because the child is very unlikely to go beyond 5 years. But of course, neurocognitive, endocrine, hearing, everything. I mean, we discuss all toxicities. Yeah. But I think we also emphasize that unless you treat the child with radiation, you will never encounter those late toxicities because the child will not survive. So I think it's important to balance the risk benefit. I mean, sometimes in our zeal to tell them about the toxicities, we sort of tilt the balance towards no treatment. Many parents actually don't take treatment because of the fear of the late toxicity. But they need to understand that if the child survives, then only he develops late toxicity.
Yeah. So another question: do we should we include entire vertebra in low dose region to avoid growth abnormalities?
No. So I think that concept is valid only for the proton world. So current guidelines for proton do recommend that in children you have to include the entire vertebral body. For photon based irradiation, there is no such recommendation. I don't do it, and we haven't encountered any significant spinal deformity since the last 15 years that we have been doing rotational IMRT for craniospinal radiation. So proton, yes, at least at this point in time, that's the recommended thing to do, not for photons.
How much extended SSD we can plan if field is not adequate to cover spinal field?
I mean, that depends on your machine. I mean, typically, I think all Linux probably can get into 125, 130 SSD. But you have to understand that the exit doses increase significantly. So we don't use extended SSD. We would rather use 2 adjacent spinal fields at the standard SSD.
Okay. Dr. Shagun has asked, any concern regarding additional dose with daily imaging?
I certainly don't think that the kind of dose that these children get. I mean, of course, there will be additional dose with imaging, but modern, even the cone beam and even the tomotherapy MVCT, they add 0.5 centigrade or 0.25 centigrade. So I would not be very concerned about that. I think with the image guidance, we have so much more confidence in the treatment that we deliver. I mean, I think that surpasses every thing else.
Yeah. You are very right. And another question is, at junction, how much dose is acceptable?
That is a difficult question. I mean, ideally, you would want no hot spot, no cold spot. In real life, it doesn't happen like that. So in the last 1 year with the VMAT, we have been trying to do something known as a robust optimization with auto feathering. The newer versions of the Eclipse allow that sort of a thing. That ensures that nearly the junction really doesn't get underdosed or overdosed. But in general, in principle, that's why you feather the junction, because if your junctional area is covered by more than 80 to 85% of the dose, I think that should be okay. With the fixed field geometry, to expect more than 90% dose is very difficult. Then you will have to abut the junction, and then the potential for hotspot and leading to spinal cord myelopathy. I mean, you'll have to be prepared for that. So we don't abut. Many people do abut the junctions. We keep a 3 to 5 millimeter gap definitely. So we get between 80 to 85% coverage at the junction once we do the feathering.
Mhm. One question is regarding high risk and low risk categories you have described. Is there any dose difference in these categories?
Yeah, so traditionally you would give 23.4 to the, so low risk is only the most recent thing, the Wnt pathway and the group 4 with the chromosome 11 loss and the 17 gain. Any de-escalation should be done in the context of prospective clinical trials. We burnt our fingers despite the clinical trial. I mean, we started, we omitted the CSI, did focal RT alone. The Johns Hopkins did, they eliminated radiotherapy, they give chemotherapy alone. Both of us burnt our fingers, but at least it was done in a clinical trial, and we both groups stopped the enrollment on those studies. So now we have a another successor study to the Forvent, where we have introduced low dose CSI, 18 gray CSI, but again that is being done as part of a clinical trial. So we should not do anything outside of clinical trials if we are de-intensifying or intensifying chemotherapy based on the risk stratification.
Yeah. Another question, re-radiation in relapse cases. What protocol, RT doses, and what care should be taken? Re-radiation.
Yeah, this is, I think, I mean, we published our experience of re-irradiation a couple of years ago. I think that was the largest experience of re-irradiation in medulloblastoma, 28 patients. Since then, we have maybe treated another 15, 20 more. I think it's a difficult decision. Traditionally, re-irradiation was never considered a very good modality in medulloblastoma, despite the radiosensitivity. And I think reason generally was the sort of toxicity that you would encounter. And as you can see, a lot of the North American and European world was trying to even reduce radiation or eliminate radiation in children with medulloblastoma. But I think case selection becomes the key. So if you identify a good biology disease, long disease-free interval, previously treated with a lower dose CSI, say 23.4, focal only relapse. So it could be a metastatic relapse, but there's only one site of relapse. So those kind of patients, I think you can select and treat them. We typically give almost full dose if it's a focal relapse, certainly 45 gray and above. I mean, between 45 to 50 gray. Anything less than 45 gray, I think curative intent irradiation will not, I mean, then that's palliative intent.
Yeah, someone had asked, are there any trials that are evaluating low dose CSI? That I think you have answered.
Yeah, there are at least 4 such trials that are looking at low dose CSI. The St. Jude's is looking at 15 gray. The other 3 groups are looking at 18 gray.
Okay. And is there any role of concurrent vincristine during radiation?
So that's a tricky question. So the traditional Packers regimen was with the concurrent weekly vincristine. Since the last 7-8 years, we have given up concurrent weekly vincristine. Even the North American trials now don't necessarily use concurrent weekly vincristine, but the original Packers regimen was concurrent weekly vincristine. So if somebody uses it, nobody can fault that person. I mean, it depends on your practice. We used to give concurrent weekly vincristine. Since the last 7-8 years, we've stopped using it.
So next question is, isosensor should be on vertebral body or adhere to vertebral body? So
this depends on whether you are doing a fixed field geometry or you are doing craniospinal. Whether you're doing rapid arc CSI, VMAT CSI. So what we typically try and do is we set the isocenter in the same vertical plane for the brain and the spine, and typically it should in rapid arc CSI, typically it would be anterior to the vertebral body. You can't get it on the vertebral body, then it's really difficult. Then your fiducial on the brain would go into the occipital, low occipital area. So typically it will be anterior to the vertebral body for rapid arc CSI. For fixed field geometry, we put the isocenter at the on the posterior aspect of the vertebral.
Yeah. Dr. Tejpal, when we treat ALL, when we do PCI, the field of PCI in ALL and the field of cranial radiation in this CSI, I think both are same. Is there any difference?
From scientific point of view, there should not be any difference, because in PCI also the brain field should encompass the meninges, because the meningeal is also a site of relapse. So it should not be any different.
I think this was the last question. So many questions has been asked. If Dr. Patro and Dr. Surbi, you have any question, you can ask. Dr. Shaleen, you want to say anything?
So Dr. Shaleen has joined.
Yeah, sir has joined. I just want to ask one question, Dr. Tejpal. As most of our residents are planning on the telecovalt in the UP, so this is question for them. That for the CSI, what would you like? You would like the moving field technique, or you would like the gap detection for CSI?
I did get the question. Moving field technique.
Moving field technique or gap junction technique for field matching and all these.
So we have been using a junction between the brain and the spine, and whenever we have two spinal fields, even between two adjacent spinal fields, but we move that every 5 fractions. We move that junction by 5 millimeters. So there is a gap, but we move that junction. So I don't know whether that answers the question. We don't keep a fixed gap.
Yeah,
we
it's a
feather the
moving,
junction.
okay.
So
Okay.
I think it's strongly recommended, whether you abut, whether you keep a gap, you should feather that.
Okay, thank you, sir. It was really a very nice lecture, and so much elaboration you have already covered. So I would like to invite Dr. Shaleen, sir, for concluding remark.
Morning, sir.
Really, hello. So, Tejpal, I joined at 7:45, actually, and later on was promoted as whatever, gotten on the panel, but I heard every bit of it. I said, this is a record number of questions we've had today. Absolutely stunning. This kind of interest. I have to say the attendance far more than even some of the major conferences. This is absolutely a testimony to your kind of grip on the subject and how people like it. Thank you so very much. That's all we would say. And look forward to your leadership in this. Thank you.
I think
Thank you so
the
much.
UP chapter of AROI deserves credit for starting these webinars. So I must thank Rashi and Surbi, and of course Dr. Shaleen for all their efforts.
Thank you so much, sir.
Thank you, Dr. Tejpal.
Thank you
Thank
once
you.
again. Thank you, Dr. Rashi. Thank you, Shaleen, sir, and thank you all the participants for joining.
Yeah, ma'am, one more thing that I want to say.
Yeah.
Dr. Tejpal has mentioned that we should review our plan. We also, not in this way, but we reviewed our pediatric patients. And we saw, yes, there was difference in medulloblastoma. Although we tried to start radiation within 4 weeks, but it was not so. And because of, TLC was less, so we stopped radiation. So we reviewed, then we saw, yes, we are doing some mistakes in medulloblastoma. So it is very important to review and publish also. So I will share with you that article, and that you have said correctly. What we do, we should actually review. And
I think
Dr.
audit of outcomes is really
yes,
required.
Yes.
Audit of
Yes,
processes and outcomes is really, and I think Dr. Shaleen is the best
yes.
person.
He is very much interested. Yeah, he always do. Thank you so much. Thank you.
Thank you, Dr. Tejpal. Thank you, Dr. Rashi.